This is the Prostate Cancer Epidemiology and Active Surveillance session. We have, as was mentioned, Doctors Benjamin, Carlsson, Rais-Bahrami, and Gill who will speak. So we'll kick things off with Dr. Benjamin. Thank you.
All right, thank you. I will try to go quickly for time. I have nothing to disclose. So first with epidemiology, the who, why, and when of prostate cancer. So we know that prostate cancer is the second most prevalent cancer in men, affecting 1 in 8 men. The SEER database estimates that there's over 288,000 new cases of prostate cancer this year in this country, with an estimated 35,000 deaths. But 5-year survival is touted at around 97%. So in terms of risk factors, we know that prostate cancer in general is a cancer of older age. I like to say that most patients die, or most men die with prostate cancer rather than from prostate cancer. We know that African American ancestry is a predisposing factor, with some studies showing that there's up to a 40-fold increase in risk compared to men of Asian descent living in their native country. Now, some of this can be attributed to differences in PSA and prostate cancer screening, but this variation in geographic incidence was seen prior to the boom, so to speak, of prostate cancer screening. Family history. We know that men who have a first-degree family member who has prostate cancer have a 2 to 3 times increased risk of developing prostate cancer in their lifetime. Germline mutations such as BRCA1 and 2, ATM, CHEK2 increase your risk for prostate cancer. And it goes without saying that if we check for prostate cancer, we are more likely to find prostate cancer. In terms of the guidelines, I'm going to focus mostly on the AUA and SUO guidelines that were recently updated, but at the end I will touch a little bit on some differences between those guidelines and the EAU and NCCN guidelines. Before I go into it, kind of framing why is this important and what are we trying to do. So when we initiate this conversation with patients in terms of PSA screening, what we're trying to do is to detect clinically significant prostate cancer at an early stage with the intention that we can cure it and decrease the total treatment burden on the patient. Now, we all are aware of the controversy with PSA screening in the PLCO trial, but the ERSPC did show that we were able to have a 21% relative risk reduction in cancer and prostate cancer mortality, followed up at 11 years, that persisted with an extra 5 years of follow-up. So prior to initiating screening, it's very important that we have a conversation with our patients. This should be a shared decision, taking into consideration their values, their preferences, their medical comorbidities. That being said, we may offer PSA screening to men between 45 and 50 of average risk. If they have increased risk, meaning they have germline mutations, they're of African American descent, strong family history, we should offer a baseline PSA screen between the ages of 40 and 45. After this baseline screening, we should continue to screen them every 2 to 4 years from the ages of 50 to 69. Now, what is an elevated PSA? Historically, it was kind of touted as 3 to 4 was the elevated risk threshold that we would use. But we know that PSA increases a lot of times with age, largely because the prostate volume increases with age. And so this has kind of led to a change in thought in terms of, can we define what a normal PSA value is per age? Now, many feel that a PSA of 2.5 is something that should be the threshold for men in their 40s, 3.5 for in their 50s, 4.5 in their 60s, and 6.5 for men 70s. When we get a PSA, we know that we must confirm it. We need to make sure that this is not an erroneous value before we embark on this journey of confirming and biopsy. Digital rectal exam is an option. It may be used as an adjunct, but the studies have shown that the clinical impact of DRE is mainly in the setting of an elevated PSA and the workup of that, rather than in the screening population. Regards to MRI, MRI may be used prior to initial biopsy, but it should be used for repeat biopsies. Additionally, we should encourage our radiology colleagues to adhere to the PIRES nomenclature so there's congruence when discussing lesions. Biomarkers may be used before a biopsy if you feel like it will impact your risk stratification and your treatment. We should not reflexively order these tests if the patient is low risk for Gleason grade group 2 or higher after a negative biopsy. Regarding the modality of biopsy, transperineal or transrectal can be offered. You may use MRI ultrasound fusion technology. If there is a positive lesion on the MRI, you should perform a targeted biopsy, plus or minus a systematic biopsy. When you're doing your targeted cores, you should at least take 2 cores per target lesion. And if there is no lesions on your MRI, then you should just proceed with a systematic biopsy. In terms of abnormal pathology, we do not need to immediately rebiopsy in patients who have 1 core of high-grade PIN, but we may perform additional testing such as biomarkers or increased interval of MRI or PSA screening for patients who have multifocal high-grade PIN. And we should perform additional testing in patients who have ASAP or atypical intraductal proliferation. So this slide is the comparison of some of the different guidelines. As you can see, the age of initiation of screening is similar amongst the 3 guidelines, as is the cessation age. DRE is still recommended in the European guidelines, though is an option in the NCCN and AUA guidelines. All recommend MRI. In regards to biopsy approach, the European guidelines suggest transperineal over transrectal, whereas the AUA and NCCN guidelines offer both. So lastly, I just wanted to, I think that the guidelines as they are written now offer an excellent framework for us to accomplish those goals of early detection of clinically significant prostate cancer, allowing us to achieve cure, as well as decrease the extent of treatment burden on our patients. So with that, I conclude.
Great. Thank you. Next, we'll have Dr. Carlsson. Dr. Carlsson is the Director of Clinical Research, Epidemiologist at Memorial Sloan Kettering. Thank you.
Thank you. And thank you for the opportunity to be here at the Focal Therapy Society and talk about this topic, to treat or not to treat. That is the question. These are my disclosures. So here's the problem. Prostate cancers may look the same, but they confer very different risk. So the trick is to find out what the potential of the opponent is. So you can see here 2 bumblebees, and one is very benign and kind looking, and the one to the right is a parasite. And it's very much similar with prostate cancer, as you know. It's a heterogeneous disease, and it's all about stratifying risk. So how can we do that? Well, we can look at everything we have in front of us. We have the man's age, his PSA, his Gleason score, his tumor stage, and the amount of cancer in the biopsies. And then we can put that into a nomogram, and that can give us some predictions of outcomes in the future that we can use for counseling. We can also look at genetics, genomics, we can look at the MRI, and we can look at what's under the microscope, and we can Google doctor talking to patients, and we will find Dr. Pinto talking here with a patient about focal therapy. Still are. Engaging in shared decision-making with the patient about what's important to him. Excellent. Because really it's not so much about to treat or not to treat, and not so much about life and death, but it's more about what's the patient's interest. What is his interest in quality of life and preserving quality of life. Because we can take out every man's prostate at an early age. We can send them to surgery or radiotherapy or focal therapy. But if we do that, these might be the consequences for a man's life. So we really have to consider the options and thinking about perhaps not so much if to treat, but when to treat. And so at the EAU in Milan earlier this year, Freddie Hamdi and Jan Donovan presented the updated results of the PROTECT trial. And as you know, there was no difference in prostate cancer mortality at 15 years between the trial arms, but there was an increased risk in metastases with the active monitoring in this trial. And we also saw that the outcomes continued to be affected even 12 years out. So significant quality of life changes in incontinence, sexual dysfunction, and bowel dysfunction. But if we also know that in the PROTECT trial, active monitoring was slightly different. It was basically PSA-based, and also the inclusion criteria was pretty broad. But in our series, and with Lori Klotz's series and others, we know that active surveillance is a safe strategy for appropriately selected and carefully monitored men, and that includes some men with grade group 2 as well. And we know that active surveillance continues to increase. This is Matt Cooperberg's data, but there's still overtreatment. So about 40% of men are still treated with low-risk disease. What about genomic classifiers? Well, we can use those to derived from prostate biopsy to augment our decision-making. And there are several out there, as you know, with Polaris, Decipher, Oncotype, and ProMark. And how do we use them? Well, the AUA guidelines says that we should only use them if they may alter our decision-making. So, for example, they can be helpful if a patient has a high volume Gleason 6 with multiple callers involved, or someone with favorable intermediate risk who is interested in active surveillance. Not so helpful with low volume disease of 6 because of the good course, as you know, or men with favorable intermediate disease who already made up their mind about treatment. And Matt Cooperberg talked about this recently in this really nice Euro Today interview, where he talks about how genomic testing can help decision-making in the moment and also help us sort of have a sharper crystal ball of what will pan out in the future. And he gives another examples here, similar that someone with high volume 3+3, or someone with a strong family history or BRCA2, 1 or 2 mutations and Gleason 6, and those with low volume 3+4. And he also talks about the importance of taking into account the volume of pattern 4 and the subtype of what the tumor looks under the microscope, and of course a man's interest and his age and what's his quality of life, and is he interested in family planning and so on. So all these nuances go into the decision-making. Something that we've been very interested in at Memorial is quantitation of the pattern 4. So we know that the percent pattern 4 can provide additional sub-stratification of risk beyond the traditional Gleason groups. And our pathologists also measure the millimeters of pattern 4, and that seems to be a very strong marker of both adverse pathology and BCR. So men with very small millimeters, so less than 3 millimeters of pattern 4, they have the same risk as men with grade group 1 disease. And this is the same with the total length of pattern 4. That seems to be a very strong prognosticator of adverse pathology, and more so than the maximum percent and the overall percent of pattern 4. And again, associated with BCR as well as an endpoint. So in conclusion, one size does not fit all. It's all about risk, and with improved risk stratification, we can really provide the right treatment to the right patient at the right time, as my chairman, Dr. Scardino, used to say. Thank you so much for your attention.
Thank you. Next, we have Dr. Rais-Bahrami, is a professor and interim chair at the UAB.
Thank you, Minhaj, and thank you for the organizing committee for inviting me to give this talk. So I will start off by saying the title was given to me, and it's a tall order because I don't know if there's a right answer. So how to decrease the morbidity of focal therapy surveillance, so after treatment, yet maintaining the ability to still rescue those with recurrent, or I would say persistent disease. My disclosures. So I'll identify basically the lack of data on this topic and the fact that we as a society probably do not all conform in our practice patterns in this space. Based on that, I'll sort of pivot over and talk about my personal perspective, what I do at UAB and in our institution, with some of the rationale of why we've landed on this protocol right now. And then I'll promote, hopefully, thought and discussion within this group that we can go to the next step and come up with a best practice moving forward. So what are we lacking as a field? And I just put this in. It's obviously not something you will find in any of the NCCN guideline versions, including the one from this year. But I would love to see surveillance following focal ablation as an added page. So there's a huge degree of variability that we see in our post-focal therapy treatments. So PSAs, some would say doing them every 3 months. Some would say really there is no PSA definition of behavior and triggers that would necessarily portend worse outcomes, so perhaps 6 months or even another cadence that we could do. There could be MRIs that we do, but they range, even in a consensus statement that I'll bring up, between 6, 12, 18 months after treatment. Or do we trigger the MRI only pending PSAs that do not behave in a way that we would expect? And then it was discussed in a few of the conversations earlier today, but where does PSMA PET fall for assessing intraprostatic either persistence or recurrence or multifocality? I think that's something that we all have to start thinking about. And then biopsy, we all agree that there is absolutely a role for biopsy, especially for subtotal gland ablations that we're talking about. But when, how often, and is this a perpetual serial thing, are men that have been effectively treated with focal therapy now on active surveillance, even in the absence of provable viable disease? So we do have this consensus statement from 2020, allowing not only nomenclature, but methodologies for surveillance after focal therapy. Many of the people in this room were involved in developing this. And that's where we started with our program developed at UAB. We started very much with that consensus statement or like-mindedness to that consensus statement. Originally, our focal therapy program, we conducted frequent PSAs on a quarterly basis in the first year after focal ablation, an MRI at 6 and 12 months, and biopsies no more than 12 months after the ablation, typically at or slightly before 12 months post-ablation. But those men were relegated to serial biopsies even when their post-ablative tissue sampling was actually all benign. We would again biopsy them at a year and then 2 years after, so 4 years out. And this was reflective of our early experience in the program. And it was also based on the consensus statement and the ranges given by that consensus statement in 2020. So as we've done this, we've developed more and more comfort. And with our post-ablation MRI really correlating well to the targeted biopsy pathology that we've learned about, we've evaluated, we've decreased the frequency. And whether that's right or wrong, that's what we are doing, that we do a biopsy, I'll show you at 1 year time. And if it's benign at that point, we basically reset the man to a new screening. So a lot of this is evolution of techniques. So I would say environmental pressures are driving change over time, and that's certainly the case at our focal therapy program. With our own experience, but also the pressures that we've learned from patient experiences, that's what's led us to evolve or change our habits and our protocol. So this really comes down to being a value proposition. What is worth finding at what cost? And so it's true value assessment. And that's assessing the morbidity of the serial biopsies versus the clinically significant prostate cancer findings they may garner. And so our typical workflow now has landed at PSA at 3 months and at 6 months. And if there is actually a decline post-treatment, as would be expected based on the volume of the gland treated or the percentage of the gland we estimated was undergone ablation, we then subsequently would push a PSA and imaging to about a year post-ablation. At that time point, we would use that MR and do a biopsy to assess in-field and out-of-field persistence or recurrence of disease. And then really that's the trigger. At 1 year post-ablation at our place, we then decide whether or not benign tissue is found, and that really goes on to a surveillance pathway, or prostate cancer is found. They either need additional treatment through a salvage technique of whole gland therapy, a repeat focal ablative therapy of some sort, or is it active surveillance worthy at that point? So really that 1 year post is when we then define where is this man de novo with his new baseline prostate. So next steps. We know that at this conference we've learned about all these techniques that we have at our centers or our colleagues have at nearby centers, and I can go on, and agnostic of what technique may be used to treat prostate cancer, I would ask whether or not one unified follow-up would actually suffice. All the different technologies, all the different approaches that we may employ for subtotal gland therapy are different, but don't they have the identical end effect that we're looking for? And what is the time to achieving that goal with each of these technologies? Because that's when we want to do the biopsy. That's when we need to assess their effect. And then what is the imaging appearance? And several of the posters actually did a really great job in identifying the imaging characteristics after certain modalities of therapy. I think that's one thing that we as a field will probably need to define more fully. And our goal, again, is to decrease morbidity of our surveillance. We want to keep patients safe. We want to have an opportunity to salvage. But I think catching prostate cancer persistence at 6 to 12-month follow-up, detecting prostate cancer thereafter only for cause, either PSA, imaging, or symptomology, is probably the key. And so history repeats itself. I know I'm going over, but looking back, even back to, 1937, so the removal of half of the prostate in which the carcinomatous nodule lies, along with its capsule and SVs, and vas deferens may be entirely sufficient. I wonder if they had a good surveillance protocol after. Thank you.
Mm-hmm. Wonderful. And last but certainly not least, we have Dr. Gill, Chair and Professor of Department of Urology and Associate Dean of Clinical Innovation at USC. Thank you, Dr. Gill.
Thank you. So I've been asked to talk about the maturity data from these 3 seminal trials that have helped shape the field and what, if any, implications this may have on focal therapy. Since it's a lot of data, I'm just going to put the overall take-home slide right off the bat. So this level 1 evidence has clearly shaken the field and contributed fundamentally to our knowledge. It has indicated that active surveillance is appropriate for lower risk disease and maybe even more. For higher risk disease, radical therapy provides only marginal prostate cancer specific benefit in PROTECT, less than 1% at 15 years. Yet, radical therapy does have its sequela. The functional hit is significant in incontinence and erectile dysfunction. So overall, looking at this mature data, I could not find any justification in doing more radical treatments for low or intermediate risk prostate cancer. The value proposition of radical prostatectomy starts kind of crumbling a little bit for men with intermediate risk disease, where we may not really be benefiting them from the oncologic perspective, yet we are certainly compromising their function. And these 3 trials are relevant for us today in the intermediate risk population, and if anything, they shift to the right and expand the unmet need space between active surveillance and radical therapy. And prospective trials are obviously needed to evaluate these less aggressive treatments in this unmet need space to try and to legitimize focal so that they can be included in the guidelines. So this is the unmet need. As we all know, prostate cancer is continuum spectrum of prognosis, yet the treatment options are binary at the extremes. And for low and high risk disease, we are good. But for intermediate risk is where all the issues come up. Focal therapy clearly has the potential to answer this. Here are the 3 trials. They basically complement each other and are spaced about 5 years apart in their duration. PROTECT is the most recent, and that's what I'm going to focus on. That's the one that has built on the others. So, but I'll make a few comments on the other ones as well. So for the SPC trial, radical prostatectomy versus watchful waiting, 29-year overall follow-up. 3/4 of the men had T2 disease or higher. 1/3 of the men had Gleason 7 or higher disease. At 23 years, distant metastasis, radical prostatectomy cut it by pretty much half compared to watchful waiting, so that was a benefit. And in the overall mortality, 2.9 years gained in the radical prostatectomy group. Overall and cancer-specific mortality were in favor of radical prostatectomy. Where was the biggest survival advantage? It was in the younger men less than 65 and in intermediate risk disease, which is where the maximum survival advantage was noted with radical prostatectomy. So the conclusions of this trial were that The benefit of radical treatment is consistent over time, but most in men who are younger and intermediate risk disease, generally prolonged survival, and the rationale for less radical treatment certainly is there in certain subgroups. Moving on to pivot, radical prostatectomy versus observation, 22-year overall follow-up. No real difference in prostate cancer or overall mortality between the observation and radical prostatectomy arms. Yet there was significant morbidity from incontinence and erectile dysfunction in the radical prostatectomy group. Clearly, there was quite a bit of crossover in these cohorts. So that is the take-home message here. Really no benefit of radical treatment in the overall cohort, but a significant burden from this active management. Moving on to PROTECT, active monitoring versus radical prostatectomy versus radiation therapy, follow-up 15 years. It's a UK trial, clinically localized disease, about 500 men in each of the 3 categories. And the thing to notice is that in PROTECT, it actually had higher risk disease than is commonly realized. Since trus biopsies were the ones that were done to document prostate cancer, MRI biopsy was not used. And so at baseline, 1/3 of the men had intermediate risk disease, and 1/3 with GG1 disease were upgraded at prostatectomy. So this is how the breakdown was in the PROTECT study population with trus biopsy. Had they had MR biopsy, this is what would be the true burden of disease in these men with more higher risk disease. Active monitoring clearly does not mean no treatment. At 15 years, 61% of the men in the active monitoring group had converted to progressed to radical therapy. And 24% of active monitoring men were alive and radical treatment free at 15 years, 24%. And the proportion of these men decreased with higher grade group or stage or risk stratification. Radical prostatectomy had worse continence outcomes. You can see the red lines is all radical prostatectomy. And again, worse ED outcomes. Again, the red is radical prostatectomy. But these are aggregate continence and potency outcomes. Let's look at new onset. New onset only during the course of the trial. And so in this regard, active monitoring, the incontinence is lesser as radiation therapy compared to prostatectomy. The erectile dysfunction, again, significant in radical prostatectomy and radiation. And notably, even in the active monitoring group, reduction with new onset ED, reduction in year 1, 2, and 3, likely reflecting the crossover to radical therapy or just the stress of diagnosis. Metastasis-free survival and cancer-specific survival. Metastasis-free, significantly lower metastasis-free survival in the active monitoring arm, but this did not translate into cancer-specific mortality. And so let's look at this a little bit. At the 10-year analysis, metastases were significantly higher in the active monitoring arm. The p-value is listed there. However, prostate cancer mortality, no difference. And it was suggested that it's because it's only 10 years, let's wait for the 15-year outcomes, and then we'll get this difference in mortality. Well, here are the 15-year data. Again, metastases continue to be higher in the active monitoring arm, yet no difference in the prostate cancer specific mortality aspect. So it did not really pan out, that 15-year thing that we were waiting for. And looking at it in even more detail, these are all data from the supplementary materials that are accompanying this article. But bottom line, even at 15 years, we have not been able to see the increase in prostate cancer specific mortality despite a higher metastatic incidence. So maybe at 20 years. But looking at this in more detail, not all metastases are created equal. In the active monitoring arm, 30% actually had just nodal disease and not distant or bony disease. And we know that regional disease, lymphatic disease, does not drive mortality at the 5-year point. And so therefore, given that most of the metastases in the active monitoring in this study are regional nodal, it's not a given that at 20 years, we're going to see the difference that we have not seen in 10 or 15. So the key points about PROTECT are 1/3 of the PROTECT population had intermediate to high-risk disease. MR biopsy would have picked it up. The primary endpoint of cancer-specific survival, really no difference at 15 years. And even pre-specified subgroup analysis did not show impact of treatment effect. Radical prostatectomy and radiation did have a significant functional impact. The secondary endpoint, as I mentioned, metastasis-free survival, higher in the active monitoring group, but did not impact mortality. Time will tell. Active monitoring did not mean no treatment here. Greater than almost 60% of men had radical therapy in the active monitoring group. And this is the backdrop to the equivalence in prostate cancer mortality that has been shown. PROTECT-T does not give license to leave grade group 2 disease or greater untreated. Only 11% of the men with GG2 or higher disease at baseline were alive and without treatment at 15 years. So does all this clarify or confound further the role or selection for focal therapy? And I will just close by making a few final slides, which is focal therapy balances treating what we know with an acceptable risk of leaving the unknown. Leaving some GG1 is fine, and maybe even a small amount of GG2 may be reasonable. But PROTECT-T did show that immediate radical treatment for GG2 or higher disease may not be warranted, provided it's eventually treated. For diagnosed GG1 disease, out of field, clinically significant prostate cancer within 2 years is in about the 7% range, and here are 3 studies that show it, which could either be just observed or refocal therapy. GG2 miss rate increases in men diagnosed with higher grade group at baseline. So it's not a simple thing. Let's start treating GG2 or GG3. We are going to have missed cancer in the untreated area, and this is shown by Befar's very nice study showing a 28% out of field GG2 positive biopsy rate. And this is also consistent with the PROMISE trial with the NPV of 76% for MRI to detect clinically significant cancer. And some unknowns remain, which is in men already diagnosed with GG2, what is the probability of having greater than GG2 elsewhere? And in men diagnosed with unilateral only prostate cancer with MRI, what's the incidence of GG2 in the opposite lobe? I will just conclude back to the overall message then. This has been through a lot of data here, but just to say that these studies have fundamentally changed the way we think, and basically does not give any real impetus to do more radical prostatectomies for intermediate risk disease, but instead consider doing studies to come up with lesser aggressive focal treatments such that we can really get the necessary level 1 data to get stuff into the guidelines. Thank you. Sorry I went over.
All right.